of the foundation doctors at Sandor Hospital, and I've got a presentation today on lung cancer. So the learning objectives will go through taking your comprehensive history, being able to spot the signs and symptoms of lung cancer, be able to explain the different investigations used in diagnosing lung cancer, as well as the principles of staging. We'll outline the different modalities of management and treatment, as well as treatment for specific symptoms in lung cancer, and we'll go through the roles of the different MDT members. So firstly, history taking. It's really important to take a good history, as we all know it accounts for about 80% of diagnosis. Presenting complaints, so why the patients come in, they might present with a variety of different things, including a persistent cough, recurrent chest infections, coughing up blood, having shortness of breath, or some of the general cancer symptoms such as weight loss, night sweats, fatigue, and feeling generally under the weather. It's also important to think about drug history, such as drugs like amiodarone, methotrexate, and chemotherapy, as they can contribute to fibrosis, which could either be confused with lung cancer as a differential diagnosis, or fibrosis can in fact be one of the risk factors for lung cancer. Really important getting a social history. So lots of lung cancer is linked to smoking. So we want to know how much they've been smoking, what they've been smoking, how long they've been smoking for. All of those are really important things to ask about. It's good to know about their occupation. So what they did as a job, where they've lived, whether they've got any kind of exposure to radiation or asbestos or pollution. Family history as well. So some cancers can have a genetic component, including the genetic mutations listed there. So a little more about the pathophysiology of the symptoms that patients might get. So like I said, they might present with shortness of breath, a cough, or pneumonia. This happens because there's airway obstruction. So the tumour itself is in the airways, which is stopping the air getting through, causing those symptoms. The tumour might also grow and compress on one of the nerves near the lungs. This can include the recurrent laryngeal nerve, which loops down under the aorta, and that can cause a hoarse voice in some patients. The phrenic nerve as well runs near the lungs, and if the tumour compresses on that, they might have difficulty breathing. Tumours can also invade blood vessels. When they do, these blood vessels might leak into the lungs or break down a little bit, meaning that patients can cough up blood clots, or they might get blood-stained mucus. That's the hemoptysis that we're taught to look out for as well. So there are different types of lung cancer. It's not important to know a lot about the different types of lung cancer, but just to be aware that there are different kinds. So small cell lung cancers are not the most common. They're the least common type of lung cancer. They are associated with smoking, and they tend to develop really quickly, so they metastasize quite fast. Generally tend to grow near the main bronchus in the kind of centre of the lungs, and they're actually related to paraneoplastic syndromes. So because they're a neuroendocrine cell which causes the tumour, they can have ectopic hormone production. So the most common one is that they'll overproduce antidiuretic hormone, which can cause SIADH, or they might also overproduce ACTH, leading to Cushing's syndrome. So when taking a history as well, if patients present with either of the symptoms of SIADH and Cushing's, I guess it's important to remember that sometimes, occasionally, this can be caused by small cell lung cancers. The other type is non-small cell lung cancers, so they grow more slowly and they account for about 80% of the lung cancers, and they're split into different types as well. Large cell grow throughout the lungs, and they're less associated with smoking than the other types of lung cancer. Squamous cell is definitely associated with smoking. It generally develops in the centre near the middle of the lung, and it can also cause paraneoplastic syndrome of hypercalcemia in malignancy. So again, look out for symptoms of hypercalcemia and consider squamous cell. And lastly, adenocarcinomas are more peripherally located, and they're also very much associated with smoking. So diagnosing lung cancer, along with the signs and symptoms, if you're considering lung cancer as a differential, a chest X-ray is normally one of the first things to be done. Chest X-rays also can pick up lung cancers without even knowing the patient having any symptoms. And normally on a chest X-ray, you'd find some abnormal lung opacifications. Patients can also have CTs, so this is more in-depth vision of looking at exactly where the tumour is, how big it is, and the kind of shape of the tumour. A CT PET can be helpful, again in staging and in management options. And then looking even more closely at the type of lung cancer, you can do a bronchoscopy or a thoracoscopy or a mediastinoscopy. So these are used, as I said, to kind of visualize the tumor itself, be able to see what it's obstructing. You can also take a biopsy at those points. Mediastinoscopies are also quite helpful in looking at the lymph nodes that might be affected or where the cancer might have spread to. So biopsies are used again to look at the type of lung cancer, whether it's small cell or non-small cell, and the differentiation, how well differentiated it is, and whether it's invaded into any other surrounding structures. Invasion might be into the vascular structures or the lymphatic system as well. It can look into that. It also might look for some tumour cell markers, such as TTF1. So once you've diagnosed that a person has lung cancer, it's important to look at the stage of it. So TNM staging is used for most types of lung cancers, most types of cancers, including lung cancers. So T stands for tumour. There's a scale of T0 to T4, and that is normally how big the tumour is and the location of it. So a tumour in T1 is contained in the lung, and it might be T1, A, B, or C, depending on its size. T2 is normally between 3 to 5 centimetres, or it means it's spread into the pleura or the bronchus. T3 means it's bigger than 5 centimetres, or it's spread into the chest wall, or the pericardium, or it's affecting the phrenic nerve. And T4 means that it's above 7 centimetres, or it's in any other nearby organ, such as the diaphragm, esophagus, or trachea. N stands for nodes. You can have N0, N1, or N2. N0, there's no nodes. N1, nodes are on the same side, so on the same lung. N3, nodes are kind of starting to spread across. They're in the mediastinum or in the carinus or in the middle. And N3, there's N3 stage as well, and that means that nodes are not only on the side that the tumour started, but they're on the opposite side as well, or they've spread from where the tumour is up above the clavicle, so they've spread quite far in the same lung itself. M stands for metastasis, so if it's M0, there's no metastasis, and then M1 means that there is metastasis. So again, that's split into different stages. M1A means that there's mets in the opposite lung or in the pleura, so it's spread but not that far. M1B is mets in one other organ, and M1C is mets in multiple other organs. So once you've obviously diagnosed and staged your cancer, you want to think about different types of management. There's a whole long list of management there that you can see, and the type of management will be decided by the MDT team. If a person's got quite localized disease, then surgery is a good option to try and get rid of it. Normally, small cell cancer metastasizes too quickly, so it isn't localized, so surgery isn't normally used for small cell, but small cell can respond better to chemotherapy. If someone's got really extensive disease, they may require palliative care, which is looking at the specific symptoms they're getting and treating those symptoms, which I'll go on to in a bit later. Immunotherapy options look at specific cells. It looks at the checkpoint inhibitor and allows the body's immune system to recognize and attack the tumour by turning on or off these specific checkpoints. Again, this is in non-small cell only. Photoradiotherapy is non-small cell only as well. It's a light sensitizing drug followed by bronchoscopy with a bright light, which then shines the light on the tumour cells, which kills them off using the photoradiotherapy. So a bit more about surgery in lung cancer. Depending on where the tumour is itself, depends on the type of surgery. So if you've just got a tumour in one specific area, you can just take out a wedge of the lung, making sure that you do a biopsy to use. So make sure you've got a good margin around that tumour. So that's if it's stayed in one place specifically and been picked up quite quickly. You can have a lobectomy, so where you take out the whole lobe where the tumour is. Or there's a pneumonectomy, taking out one whole lung and leaving the other lung in place. There's also, you need to be aware, removal of lymph nodes, depending on if the tumour has spread to lymph nodes, to be aware to remove those as well in surgery. In terms of palliation, so if a patient can't be managed with surgery or chemotherapy or radiotherapy or any of the other options, they can go under palliative care and have symptom management. So multiple different symptoms. First one is pain. Pain can be controlled using the WHO pain ladder that we all know. Also, towards the end, patients need quite intensive analgesia. This can be in the form of a fentanyl patch, or morphine is often used as well. Dyspnea can happen quite a lot, so patients feeling very short of breath. The first thing would be to think about the cause of their shortness of breath. So apart from lung parenchymal damage and airway obstruction from the lung cancer itself, there are multiple other causes of the shortness of breath. These can include superior vena cava obstruction. They might get a pleural effusion from fluid building up due to the cancer. They might be getting multiple chest infections, which could be treated with antibiotics. They might get anemia from a cancer, so thinking about what their HB level is and if you could do anything to manage that. As well as PEs, we know are more common in cancer, so double checking a patient isn't having a PE and could be treated with heparin or anything to remove that PE and relieve them of their dyspnea. The other thing, if it is just parenchymal and airway obstruction from the cancer itself, then oxygen can be quite helpful to help relieve patients of their symptoms. A cough can actually be helped by opioids. Codeine or morphine can sometimes help people with their cough. Restlessness and delirium, they've got multiple different ways that they can be managed in palliative care. And we have the really good palliative care team that are very helpful in managing some of these really difficult symptoms when a person comes to the end of their life. Terminal secretions as well, as we're getting really near the end of life. Sometimes helping patients kind of by turning on their sides might help them with these terminal secretions not blocking their airway or making it hard for them to breathe. Or there are drugs as well, such as glycopyrronium, bromine, and other palliative drugs that can help people with secretions near the end of life. So there's a whole multidisciplinary team involved in looking after with patients with lung cancer. So the first set of people that are going to be helping mostly diagnose. So the GP can pick up on symptoms, or ED doctors or doctors in acute medicine might be the first ones to recognise some of the symptoms that they're getting, or might do chest x-rays for other reasons and pick up on tumours in the chest x-ray. And we have pathologists and radiologists that look at the chest x-rays and the CT scans and might do biopsies, looking at the type and the stage of lung cancer. In terms of treatment, you've got the respiratory doctors themselves. There are oncologists who specialise in the chemotherapy and radiotherapy, oncology specialist nurses, and there's respiratory specialist nurses as well. They'll be well trained in looking after patients, not only the medical side of things, but the social aspect and the psychological aspect of having lung cancer as well. As we all know, cancer affects people in many ways other than just their health. Then we've got the surgeons. If a patient is appropriate to have lung surgery, they'd be involved in that, obviously. And coming to the end, we've got physiotherapists and occupational therapists. If patients aren't able to get much better, they require help at home, or the chest physios, getting secretions off of patients' chests to help them feel better. Psychologists, again, that comes into kind of the holistic approach to managing patients with cancer. And as we've already kind of described, the palliative team are really good at helping with those final palliative symptoms that patients with lung cancer can experience. So that completes the presentation, just a bit of a summary of what we've gone through already. We've looked at taking a history, the things you need to include, including the presenting complaints, drug history, social history, and family history. Multiple different types of lung cancer and the features of each of those. Been through diagnosing and imaging, and chest x-ray is the first imaging modality normally to pick up lung cancer, and that biopsy is the best at determining the type of cancer and the stage that it might be. And also that there's multiple different ways of managing lung cancer, and that there's a whole MDT which are involved in managing and diagnosing that, including the palliative care team which help with symptom management. Thank you very much for listening to the presentation on lung cancer. I hope that's cleared some things up for you.